Hi, my name is Kenneth Bailey, and together with Callum Semple and Peter Openshaw, I'm leading the ISARIC Coronavirus Clinical Characterization Consortium, or 4C for short. We're trying to answer urgent clinical questions about COVID-19, and we're very grateful for your help in recruiting patients. So I'm going to introduce Dr. Clark Russell, who is a clinical lecturer in infectious diseases and is helping to coordinate recruitment to the ISARIC4C study. Clark and I are going to go through the recruitment of an imaginary patient, and because stocks of PPE are already a concern in the UK, we're not going to wear PPE for this video, so you're going to need to imagine that at the points in the video where he says he's wearing PPE, Clark is wearing PPE.
Okay, thanks Kenny. So the most important thing for everybody involved in this study, for the recruiting staff, for the patients and for the staff in the clinical area, is that we do it very safely. And therefore all staff who are recruiting patients must be fully trained and confident in the use of PPE and specifically how it is operationalised in their clinical area. Sites will be provided with relevant documentation by the ISARIC4C study. This will include the most up-to-date version of the study protocol. It will include the patient information sheets, the consent and the assent forms for patients to complete. It will include a practical logistics guide about how to operationalise recruitment, and it will also include a sample log to record samples prior to transfer back to the central laboratory.
So the protocol that you'll receive is the ISARIC Clinical Characterization Protocol. That's a generic sleeping protocol designed for any infection. On top of it, we have produced a guidance document that specifies exactly what we need to do for patients with COVID-19. And it's that guidance document that you should follow.
All individual recruiting sites should create a site file. This should contain all of the study documentation provided by ISARIC4C and also the completed consent forms. The completed consent forms should be kept indefinitely and the site file should be kept in a locked room. The exact contents of what should be in the file are available on our website. Various pieces of equipment are required to obtain the biological samples necessary for this study. A sample pack will be delivered to recruiting sites that contain a number of these pieces of equipment. This will include an RNA tube for collecting blood, a nasal synthetic absorptive matrix or SAM strip, an Auricol oral swab, and a Category B transport package for collecting and subsequently shipping samples back to our headquarters. In addition, the sample pack will include unique barcodes that should be attached to all of the individual samples and a log in which to record the samples obtained and the unique barcodes attached to them. In addition to this, we ask that the recruiting sites are able to provide tubes for the collection of EDTA and clotted blood, and also cotton-tipped swabs and viral transport medium for the collection of viral throat swabs, as well as containers for the collection of urine and stool. Prior to recruiting a patient, we need to generate a study number for the patient. The study number consists of a 5-digit site code followed by a 4-digit patient number. In England, the site codes are the ODS codes for the recruiting hospitals, and in Scotland we are providing a list of the site codes to use. And the patient number represents the order in which the patient is recruited at a given site. Once the study number has been generated, it should be entered into the REDCap electronic system to generate a profile for that patient and the data that will be collected for them. There are two common scenarios for obtaining informed consent from patients for this study. In the first scenario, the patient is judged to be competent and able to provide informed consent themselves. Therefore, they should be provided with the appropriate patient information sheet, summary information sheet and consent form, and guided through completion of the consent form, including initials in the relevant boxes and then completion of their name, signature and date. And the consent form should then be completed by the individual obtaining informed consent. This process will be completed in the patient's room, which will be an isolation room or a cohort zone, and therefore the consent form will not be able to leave and will have to be destroyed as biological waste at the end. Therefore, After completion of the form, it needs to be witnessed by an individual who is independent from the study, and for this we would recommend nurses or medical doctors involved in the care of the patient who are independent from the study. These independent individuals should be asked to carefully look at the completed consent form in the patient's room, noting that the patient's initials have been put in the consent boxes, and that the patient has signed, written their name and dated the form, and that this has been completed also by the individual obtaining consent. The witness will then be asked to complete the witness section of a duplicate form that exists and has been filled out with the isolation area. It is this witnessed form that should be stored in the site file. The next most likely scenario is that proxy consent is obtained. In this case, a date should be decided at which to review the patient's capacity to give consent themselves, and the patient should then be visited again at this time and informed consent obtained from the patient in the way we've just described. The specimen containers and sample tubes should be labelled in a very specific way, and this should be done before taking the tubes into the patient isolation area or cohort zone. The specimen containers should be labelled with the patient's study number, with the term ISARIC research, with the date, and with a biohazard sticker. In addition, all of the specimen containers apart from the clotted and EDTA blood tubes should be labelled with the unique barcode assigned to them. The clotted and EDTA blood tubes will be subsequently processed upon arrival in the lab, and it is the individual aliquots of these samples that should have the barcode stickers attached to them, and therefore not the original sample containers. After the samples have been obtained, whilst still in the patient room or in the cohort zone, the blood tubes should be placed into one sealable plastic bag, and all of the other samples, which will include the sand strip, the oral swab, the viral throat swab, the stool and the urine, should be placed into a second sealable plastic bag. This means that the samples that the lab are required to subsequently process can be accessed separately from the other samples, which can go straight into the freezer. These two sealed bags should be placed together inside a second sealed plastic bag. Therefore, the specimens are now double bagged, and this should be placed in the plastic bio bottle that will be provided by us. This bio bottle should then be cleaned and disinfected before being taken out of the isolation or cohort zone, and it is then safe for it to be transported to the lab for processing and storage of the samples. Careful liaison with our colleagues in the diagnostic laboratory is essential to make this work, and we are very grateful to their support in doing this study. Upon arrival in the diagnostic lab, the clotted blood and EDTA blood tubes require to be processed as detailed in the logistics document. This involves centrifugation and then aliquoting of the serum, the plasma, and storage of the cell pellet. These components will be placed into individual aliquots, and each of these aliquots should be assigned a unique barcode. Therefore, the lab need to receive enough barcode stickers and know that the unique aliquots should be assigned unique barcodes, and that these should be recorded in the sample transport log. Lisa is a patient with COVID-19 who, in my opinion, as a GCP-trained healthcare worker, has full capacity to provide informed consent for participation in research. Therefore, Lisa has been provided with the patient information sheet. She has had time to read it. I have answered any questions she has about it, and she has completed the consent form. This has involved putting her initials in the relevant boxes, signing the form, writing her name and the date. I have also signed the form, written my name and written the date, as the individual who has obtained informed consent. As discussed earlier, this form can now not leave the isolation room or COVID cohort zone because it is contaminated. And therefore, Lachlan, who is either a nurse or medical doctor independent from the study, has kindly agreed to be a witness for this form. Therefore, Lachlan has observed that the form has been correctly completed, that the initials are in the boxes, and that it has been signed, dated with both of our names. And then when we leave the COVID cohort zone or isolation room, Lachlan will complete the witness section of a duplicate form, which I will then fill out with the relevant details. There are a few final points which I would like to make. Firstly, in the UK, we are aiming to collect serial biological samples on day 1, which is recruitment day, day 3, day 9, and then at convalescence, which will be 3 months after recruitment into the study. Therefore, prior to the patient's discharge from hospital, it's important to make sure that you have the necessary contact details to arrange a 3-month follow-up visit. If the patient is discharged prior to day 9, then there is no need to try and obtain those samples. It is the 3-month convalescent samples that are most useful. The case report form is completed through the REDCap electronic system, and we would ask that it is completed on each alternate day of hospital admission. On the day of recruitment, the core form should be completed. On each alternate day after that, the daily assessment form should be completed. And then, at the time of the patient's discharge or death, we would ask that the outcome form is completed. Finally, it is very important that when the samples are being shipped from the local laboratory to the central laboratory, which will either be in Liverpool or Glasgow, depending if you're an English or Scottish centre, that the sample log is completed with all of the samples being shipped, and that the unique barcode corresponding to that sample is also attached to this log. And that again requires careful liaison with our colleagues in the diagnostic lab. At that, I would like to say thank you very much for your support in recruiting to this study. And if you have any further questions, my contact details will appear next, and I would invite you to contact me either by email or by phone if any practical or logistic questions arise. Thank you very much.